All right, hello everybody. Happy Thursday night. We are here with the incredible Dr. Bill Harrell. We're so excited that you said yes to come talk to Airway Circle. Welcome.
I'm glad to be here. Thank you for inviting me.
Of course. Let me see if I can open this back up because everything closed for me. Where is it? Okay, I see it. Awesome. So I'm going to start by introducing you guys to Dr. Bill Harrell. And also, if you guys have any questions, you can post on the Facebook messages. I'll be checking over here on my phone. And if you guys are live on Zoom, just write on the chat and we'll make sure your questions are answered. I have a couple of announcements to make. One of them is that for Airway Circle members, I want to say this before I forget. Airway Circle members, if you are a member, we are having a free class next month. Every month we're trying to feature something, okay? So this month was Dr. Daniel Lopez. He did a free class for the members. And then next month we have a lawyer, Brent Saucer. He's going to be talking about trademarking and copyright. So if you have a business, if you have a logo, if you have a slogan, when should you trademark? When should you copyright these things? And how do you do it? So he's going to explain everything for us. Super excited about that. This Saturday, we have our first masterclass. It's going to be a 6-hour CEs for dental professionals. It's on sleep physiology, sleep disorder breathing, and myofunctional therapy. Evaluation and what do you do when the patient does have a sleep issue. So what is your role in the sleep team, multidisciplinary team, when we get patients like that? So it's going to be super cool. It is recorded, so if you cannot be live, it's okay. You have about 20 days to watch. But that's about it, I think, for announcements. I'll say a couple more things at the end. So Dr. Harrell is a board certified orthodontist, and he's in the process of obtaining his board certification in dental sleep medicine. Congratulations. Practice was the first in Alabama to have Conebeam computed tomography, so the CBCT, and the first private practice in the U.S. to combine CBCT with 3D facial imaging. He's on the American Dental Association Children's Airway Screener Taskforce, or CAST, which was established to develop a simplified and validated screening tool for sleep disorder breathing in children. He's currently writing a textbook on pediatric sleep disorders and its relationship to craniofacial growth and early orthodontic intervention. So, Dr. Bill Harrell, what are you going to do when you get older?
I don't know. I'm just going to keep going. Just keep going. I can never give up.
Young, and you're putting all this stuff out there. This is fantastic. I mean, seriously, people that are just 10 years younger than you are not doing, 20, 30. That in their 30s, they're not doing as much as you're doing. So thank you so much for being such an important part of our, not only airway community, but our dental community. So take it away. The floor is yours.
I appreciate that. Thank you so much. And thank you, Renata, for asking me to do this, and enjoyed this past weekend in Atlanta with the AAPMD. There was some excellent stuff going on. Enjoyed meeting you there. I'm so glad I got to talk to you today. I'm going to talk a little bit about kind of interdisciplinary management and what we've been doing with some 3D facial biomarkers, things to look on patients' faces that we kind of see every day, and then some orthodontic therapies that I think are kind of important, and how this whole thing about sleep disordered breathing involves, so many different disciplines that we all need to kind of work together and be on board. We're going to talk about interdisciplinary management between orthodontists. It includes dentists, it includes otolaryngologists. You can see even the word dentist and ENT kind of go together, don't they? Neurology, pulmonology, you guys in oral myology, orofacial sleep language pathologist, oral myofunctional therapist. We all need to kind of work together in talking and treating these kids that have these early signs of sleep disordered breathing, which may lead to other things. We'll get a couple of videos here. I hope you can hear this. Let's make sure you can. Don't you feel like that sometime?
Yes, that's hilarious.
So this little child is called Eli. His mother is a nurse, and I want you to notice he's about 3 years of age, but I want you to I'm not going to run through the whole thing, but I want you to notice she's recording him, and this is what we see on these children.
Picture of Eli holding his breath. Right now he's snoring. Let's see what happens.
And remember, he's upright and awake. I mean, upright. He's not laying down. You see that retrognathing mandible, mouth breathing.
Wow.
It kind of makes it hard to even watch this thing sometimes because you want to breathe for him. But they stop breathing.
Wow.
Taking real short breaths. You can imagine what's going on with the oxygen levels in his brain and his heart, how much effort he's having to do to try to breathe. And then all of a sudden, he'll take a gasp for a deep breath. And he arouses and watch him. It's just hard to watch that. The mother, what she'll do is, I'm not going to just go through the whole thing, but eventually what she'll do is you'll bring his mandible forward.
I can't see something.
Now watch her. She's bringing his mandible forward.
That's a brave mama right there, putting her finger right in.
Yep.
But look
Now
at that.
listen. Yep. Silent breathing. Is she gonna let go in a minute? He's gonna stay there. He'll close his lips. But now he's got silent breathing, and that's the way the breathing should be.
How many kids are sleeping all night long like this?
Just all night long like that.
Or being
So they go on and on and on. And so, what do ENT and oral myofunctional therapists and orthodontists, what do they have to do with sleep disordered breathing? Well, ENTs obviously want kids to breathe through their nose properly. Oral myofunctional therapists, speech language pathologists want, to train them how to properly place their tongue in muscle function for proper nasal breathing and proper growth and development. Unfortunately, historically, we orthodontists, we want healthy teeth and gums and TMJs, excellent bites, beautiful smiles and balanced faces. We want all that. But what we want really is we want all this together. Now, I think this is where we all got to come together and kind of in an interdisciplinary fashion to do all this together. And we as orthodontists probably have an obligation to look at this also. It's like taking a child like this, and this is some of the Conebeam and 3D facial scan stuff that we do. But I want you to look at the first picture of this child's face. You can see he's got that typical mouth open posture, the retrognathing mandible, the narrow maxilla. And one of the things with Conebeam, we can evaluate airway size and shape to a point. It's not definitive, but it's pretty good indication that, that this child has a small airway. And then when you take them and do some certain therapies, you can not only make their facial configuration look a tremendous amount better, but also look what happens to the airway and the teeth. And you can look and see in a year and a half, this child's airway went from 83. We'll talk a little bit about that. From this 83.4 square millimeters, normal for that age would have been about 100, up to about 179. And about a year and a half later, if he had just grown normally, his airway would have been about 116, but it went to about an adult size airway. So this is what I'm trying to create in some of these children, or airways bigger. I mean, obviously, if you have a bigger airway, you have more airflow. In 1889, a pediatric surgeon, William Hill, was removing tonsils from a child with obstructive airway to alleviate those struggles in breathing when he noticed an unforeseen side effect of his procedure. The tonsillectomies unexpectedly cleared up the child's chronic headaches and problems of paying attention in school. He reported this in the British Medical Journal that children, the victims of nasal and pharyngeal obstructions, frequently demonstrate a marked inability to fix their attention on their lessons or to work for any length of time. His description and symptoms are the same ones we now associate with ADD and ADHD, and these have accelerated to epidemic proportions in the past 2 decades for unknown reasons. It's interesting, I got to talking to a friend of mine. I went to a high school reunion, and a friend of mine that I went to high school with, Leighton Gordy, he and I got to talking. I did not know his grandfather was a orthodontist. And he and I graduated high school together in Columbus, Georgia. And I got to talking to him. He said, well, my grandfather wrote some books, because I was telling him what I was doing about breathing and that kind of stuff. And he said, well, my grandfather in the early 1900s actually wrote some books. And I said, send me what you have. Dr. Gordy, Perry Gordy, went to the University of Maryland Dental School in 1897. He went through the Angle School of Orthodontics, and he wrote this little book called The Nose and Throat Conditions and Allied Habits in Relation to Irregularities of the Teeth and Development of the Jaws. This was around 1920. It's interesting, if you go back almost 100 years, how much more educated we were in the area of airway than we are today. For some reason we've kind of lost track of it.
Happened.
But he wrote, a friend of his wrote a note, or wired him a note. This was Dr. Edmund Kells of New Orleans wired Dr. Gordy a note, said, you have given the profession and the world something worthwhile. Don't be discouraged. Remember Jenner, Pasteur, Rinkin, and Wells. Ignorance and prejudice burned Savonarola at the stake. This was another thing that he wrote around 1929. It's like 71 years ago. Mouth breathing and a few facts of seldom discussed. The causes and effective treatment of malocclusion, with special reference to pernicious habits as affecting the physiognomy. Not by Perry Gordy, Columbus, Georgia. One of the most prolific causes of malocclusion is mouth breathing, which not only causes malformation of the jaws and the associated structures of the nose and face, but affects the general health and appearance as well. 3 generations ago, now that's 7 generations now, 184 years ago, Charles Dickens, in his book, The Pickwick Papers, pointed out the relationship between open mouths, backwardness, and delinquency that would have saved millions of lives and would have averted millions of life failures had civilized world realized the true impact of his words. And he talked about that by a little boy named Joe. There was a little fat boy in the Pickwick Papers. That was the first time that really sleep apnea was even mentioned in the literature, and it was just in a story. So interestingly enough, that was written over 71 years ago.
That's insane. You're blowing my mind, Dr. Harrell.
It's amazing how far back this goes. I mean, here's Dr. Gimeno, one of our heroes, I guess, in this whole thing. Dr. Gimeno is the one that helped discover sleep apnea way back, and then in 1976. He was the first one to use polysomnography to describe sleep apnea in children as a combination of clinical symptoms and evidence of obstructive apneas. And luckily enough, in 2017, the American Dental Association had a policy statement about the role of dentistry in treating sleep disordered breathing. And one of the key elements, the second paragraph, it is encouraged, number one, it's encouraged for dentists to screen for their patients for sleep-related breathing disorders as part of the comprehensive medical and dental history. But also in children, screening through history and clinical exam may identify signs and symptoms of deficient growth and development and other risk factors that may lead to airway issues. If risk for sleep-related breathing disorders is determined, intervention through medical dental referral or evidence-based treatment may be appropriate to help treat the sleep-related breathing disorders and develop optimum physiologic airway and breathing patterns. So dentistry is coming to light, and a lot of this was put forth by Dr. Steve Carstensen, who was at the meeting this past weekend, and he and a number of us are on a committee for the Children's Airway Screener Task Force. So we're trying to come up with some screening devices that will help us. In other areas, the American Association of Orthodontists have kind of written a white paper on that. The American Academy of Pediatric Dentistry is stating that we need to screen these patients for snoring and gasping and sleep-related breathing disorders. We need to probably go a little further and look at the myofunctional parts and the myofunctional therapeutic parts of this also. And I think that's something that's coming down. And I hope I learned more about a lot of that this weekend, and I want to learn more about that. The symptoms of sleep disordered breathing in children by age. This was put out by Dr. Sinha and Dr. Gimeno in 2010. By age, what things that some of the symptoms that you should be looking for, such as snoring and witnessed apneas and frequent arousals, mouth breathing, the nocturnal sweating. You can see how a lot of these are similar, but they tend to grow as the child gets older and older and older, and the list gets longer and longer and longer. And especially in the area where, me as an orthodontist, where I should be looking, I should probably be looking even younger than this, but the American Association of Orthodontists says that orthodontists should start screening patients around 7 years of age. We'll talk a little bit about why that's probably not early enough. I think it should be earlier than that, probably even in the 4 or 5 year of age range. But especially when we're seeing some of the older children, then I'm even screening. If the parents have younger children in there, I'll ask them about, does your child snore? And we'll talk about some of the signs, some of those facial signs that we look for on the children. But these are just some of the symptoms we know about. A lot of these: the nocturnal sweating, the hyperextended neck, the drooling, the confusion, the sleepwalking, the daytime sleepiness, enuresis, which is an autonomic kind of reaction to lack of oxygen, and a lot of these things. The problem in the children is it leads to these consequences in adults, which are pretty major things. It's been shown that stroke may be, related in a heavy way to sleep disorder, or the consequences of sleep apnea, hypertension, heart disease, cardiac arrhythmias, heart failure, heart disease, sudden death. All these things tend to have significant cost in our healthcare system, obviously. And a lot of this may be, Dr. Gimeno thought that some of these things could be prevented or lessened if we would recognize these things earlier in life and did some kind of treatments on some of these patients. And I think he was right. It's just hard to, people always ask for evidence-based treatment or evidence-based information about some of these things. And some of these are hard to actually come up with the definitive answer, because some of the research that you would have to be able to do to answer these specifically are just about impossible to do. But still, you got to take little snippets of the research and use your mind and use common sense to say these things are related. And you can look at some of the animal studies that have been done in the past too, to kind of help you get through that. This is a starting of a screening form that we started with the Children's Airway Screener Task Force, which a number of us, maybe even on this call tonight, are on. But Dr. Jerry Simmons, who was at the meeting this past weekend, gave some great presentations. Steve Carstensen is on that committee along with some others. And what we wanted to do is come up with an easily incorporated into a dentist or physician's office or other healthcare provider that really, this is not for people that necessarily know a lot about all this. This is for doctors that may not just want to screen for it. So what we're asking them to do is to come up with the first little form is just a simple 5 questionnaire. This is still in draft form. It's not been it's not for prime time yet, but because we want to validate it. But what this does, except for when your child is sick, they typically breathe with their mouth open or lips apart. Or do they tend to snore, have pauses in breathing? Do they frequently have any of the following: the tossing and turning and kicking, and sleepwalking, or talking, or clenching, or grinding? In the morning, do they have difficulty waking up, nasal congestion, mouth pain, jaw pain, headache? Or do they frequently have, we don't say ADHD, but we say behavioral issues, emotional issues, or poor performance in school? And the point is, any yes answer that's elicited in this simple little questionnaire elicits further evaluation. And then what we do there is we make it a little bit more specific with each of these questions and ask, you said they breathe through the mouth. When do they do that? While they're awake or asleep? Do they have lips apart, awake or asleep? And you can see they get a little bit more specific into those questions. We won't go through all these, but you can see that what we're trying to do is to come up with questions that seem to be related as specific as we can to these sleep disordered breathing issues. I came up with, this is kind of a flow chart of kind of the way I see things. It's kind of how I'm gonna get some of this stuff out of the way up here. It's kind of how my book that I'm kind of working on going to be laid out. But I'm going to go over some close-ups of this. But I wanted to kind of show you how, I guess, detailed this is, because you start at the beginning. The beginning is up here at the top. Environmental, pre-industrial revolution things. I mean, before birth, before conception, the health of the mother, the genetics, the environment, the nutrition, the delivery method, the nutrition during whether the child's breastfed or not, or when baby food is introduced into the system, the habits and things that can go on. Obviously, allergies and allergic rhinitis, and a lot of the anatomical features. But they all lead into areas like there's a lot of what's happened since the post-industrial revolution is because of a lot of things, the foods, the contactants, the allergens in the air. You get allergies, release of chemical mediators. We're not going to go through all this, but you can see you get the whole stage is set for lowered oxygen saturation at the bottom down here. So you get this lowered oxygen saturation, and then that leads to decrease in nitric oxide, malocclusions. It all leads into snoring and sleep apnea and all these other things. I'm going to show you a little closer up view, because one of the things we're going to talk about today over here are these kind of 3D facial biomarkers. What can we look at? What can we see on the face? Some of them we already know, but sometimes we don't see the forest for the trees sometimes. But I want to look closer at these 3D facial biomarkers themselves. But you can kind of see how I've kind of laid this out, and how one thing leads to another, shift from nasal breathing to mouth breathing, how that lowers oxygen saturations, interferes with facial growth and development. Here's kind of a close-up of the 3D facial biomarkers. We'll talk a little bit more about them, how the interference in growth, poor eating habits, lowered resistance to infection, nasal obstruction. I mean, it goes on and on and on. And we'll keep going. We're just kind of, I'm not going to get specific, but here's your high arch palate, your mandibular recessive, your malocclusion, poor tongue repose. This is what oral myofunctional therapists need to help us with: interference in anti-open bite, facial grimace, malocclusion. You just see it kind of goes on and on and on, and then ultimately even leading to potentially for sleep apnea and lower oxygen saturation and all the comorbidities that can be associated with that. So I'm not going to get into that too detailed, but you can see how I think the flow chart kind of goes or what my thought process is. This is, we'll talk a little bit about Conebeam CT, but this is kind of a sister technology to that. This is called 3D facial imaging. I actually have one of these cameras in my office that takes 1.5 milliseconds. It actually takes a true three-dimensional 3D image of the face. And from there, we can do a number of measurements, and we got accurate data, shape data, and geometry data that we can look at as far as things that are going on the face of these children, which I'll talk about a little bit more. But are there signs or biomarkers on the face that relate to respiratory issues leading to possible sleep disordered breathing in children? And I believe they are. I mean, here's some of them right here. The key ones are these allergic shiners. These are very common. The problem with things that are going on now, this is so common that people kind of consider it normal, but it's not really a normal. This is not a normal face. She's got a long facial pattern. She's a mouth breather. You can see she's got real small nares openings. She's got real narrow face. But the key elements, looking at the eyes and looking at those dark allergic shiners. This child has the same thing. She squints her eyes. I mean, when you have a lot of these allergies, what do? They tend to squint their eyes. She's also got this thing called a transverse nasal crease. When they wipe their nose a lot, what do? They get this transverse nasal crease that they wipe across their nose. So some of these things can actually be analyzed, and that's kind of one of the things that I'm kind of looking in the future at, is to be able to maybe on an iPhone or something like that, maybe take a three-dimensional image and have this analyzed and actually have these things quantified in a little bit better way than just visually.
Wow.
So these are some of the things that I've come up with, just a real partial list of allergic shiners, the bags under the eyes, the oral apertures. The oral aperture tends to get smaller because what do? They're kind of squinting their eyes. The nasal openings get smaller. The transverse nasal crease, that's called the allergic salute. We'll look at that. I'll look at some of these other things and show you specifically what I'm looking at. Here's the allergic shiners. It's called periorbital hyperchromia, but it's really a lack of venous drainage back into the sinuses of why these things show up. And again, in this little child's face, you can see she's got real small nasal openings, obligate mouth breather, long, narrow face. You see these bags under the eyes that tend to be a longer term version of the allergic shiners. You get spasm in the muscles. This is called Denny's sign. We're going to talk a little bit more about it. I'll explain that in just a little bit. Here's the transverse nasal crease, which you can see on patients, and we're going to talk a little bit about this other figure here about the malar region. I'll get into that in just a second. All right, so here are things that we see, that we see all the time, and we know about these allergic shiners. But you could grade these things as light, medium, dark, blue, brown. I think the darker they get, the worse they are. But what happens is in the allergies, the turbinates, and they tend to swell up. What do? You tend to get allergic rhinitis. All this area in the nose tends to swell up. The veins that are in the nose don't drain properly back into the pterygoid plexus. So the blood in the vein tends to stagnate in these areas, and they get inflamed. And then what do you see? It all comes out up there under the eyes as an allergic. That's what we call an allergic shiner, or those dark circles under the eyes. And then you get infraorbital, this venous pooling. You get this infraorbital edema that can form, and then you get a spasm in this, what's called the muscle of Mueller under the eye, and you get bags under the eyes. And as we get older, we older people tend to have these bags, and we tend to buy creams and things like that, tend to shrink those things down. You've seen them on TV where they magically disappear. But there's a color and geometry part to this, and that's kind of what intrigues me about some of the 3D facial imaging, that this has a possibility in being able to maybe analyze these a little bit more. These are those little, what's called Denny's sign. They're specific to allergy. They're actually, they're called Denny Morgan's lines or Denny Morgan fold. But again, when a patient squints a lot, when they got allergies, what do? The allergies are in their eyes and in their nose and then the whole nasal respiratory area. And they squint a lot. So what do? They get these skin folds start to show up. And the presence of Denny Morgan folds is used as a diagnostic marker for allergy with a sensitivity of about 78% and a specificity of about 76%. Now, that's not 90%. We tend to want to say that's our evidence-based number. Look, this is 3 out of 4 kids. This is 3 out of 4 walking in the office that have this. To me, that's still pretty significant numbers, and you see this all the time. And what these things do to me is when I see the allergic shiners and I see these things on the kids' faces, what's my first conversation? Does your child snore at night? Does your child stop breathing at night? Do they sleep good at night? And usually the answer is no. And then that just opens up that whole conversation about the 5 questionnaire kind of, again, it just opens up the conversation to talk to the children. And then when I talk to the parents about the child and their sleeping habits. Now, this is an interesting article that came out in 2019 by a group in Australia. And I thought it was really interesting. I haven't heard much more about it, but it's predicting sleep apnea from 3D facial photography, which is kind of right up my alley. They took a group of patients, and what they did is they located these 3-dimensional landmarks on these facial surfaces. And they did 2 different measurements. They did linear measurements across certain anatomical regions, just as straight as the crow flies from certain areas to certain areas. But they also did what's called geodesic lines. In other words, from those same landmarks, but they measured over the contour. And what they found was when they combined these 2 together, these 2 measurements, they were almost at about a 90-something% predictive value. In conclusion, the main findings of this study was that geodesic and linear measurements add value to the capacity to identify patients with OSA from 3D photographs of the face. The results suggested it might be possible to predict the severity of an individual's OSA from such photographs. Now, just think about that as a possibility. If that were true, if we could create somehow a iPhone app that could not only, obviously you're going to do more definitive study, but this is a potential screening device that might even be potentially used to do that. So, and I found that too. I'm going to show you in a little bit some of the things that we found on certain of these faces of patients that I see very commonly and that might fit in with this. This was another study that was done at Cardiff, Wales in the UK by a friend of mine, Steve Richmond and Ali did a study. They took the 3D MD facial capture system, which is what I have, and the title of it is The Influence of Snoring, Mouth Breathing, and Apnea. You can see it was from the UK, by the way they spell apnea, on facial morphology in late childhood, a 3-dimensional study. They took 15-year-olds. All of these were 15-year-olds. They had 1,724 children that had documented sleep disordered breathing. Now, these were not documented with polysonography. I wish they had been, but they were documented with like a pediatric sleep questionnaire. They had another 1,862 they considered healthy that were all negative on the health questionnaire. So what they did is they took all these 1,724 kids with sleep disordered breathing, and they made a common three-dimensional shell of their face. Let me move that out of the way. And then they took the 1,862 healthy children and they made a common shell of those children, and they mapped those two together. Now, what they found was, let's go back, when they mapped those two common shells together, everything that's pink is about at the same level. Everything that's red is toward you, and everything that's blue is either away from you or open or more narrow. In other words, if you look at what you're looking at here, the blue is the relationship of the nasomaxillary area of children that have sleep disordered breathing in relation to the normal children. In other words, their whole nasomaxillary region is more recessive. Their mandible is more recessive and down, class 2, and their faces are narrow. So it proves, in my mind, it proves that these kids that have sleep disordered breathing, they have narrow faces, they have more recessive, not just the maxilla, but the whole nasomaxillary complex, and the mandible is down and back. Now, if we look, this is a child, in addition to that, this is a child that I took a 3D face on, and I was playing around with it. So I took a plane. This cut plane is like a plane that actually cuts through the face. And if you look very carefully, you can see her right side of her face is more rounded than the left side of her face. And I see this very, very common. I would say over 90% of the patients, when I do this little trick, I'll find that the left side of the face is more narrow, is more flatter than the right. And even if you look at their sample here, look at the left side of the face, how much flatter it is than their right side of the face. Isn't that interesting? That wasn't even mentioned in the article. I don't know what that means. It's something that needs to be studied, but for some reason, it seems to be. I found a few where it's opposite of that, but not very many. But for some reason, the left side of the face seems to be flatter than the right. I don't know why. But anyway, what else should we look for? Of course, we got this class 2 retrognathic, usually a retrognathic mandible, but also the upper jaw may be retrognathic. They may be class 2, where it looks like the upper jaw is actually protruded, when in actual fact, both jaws may be protruded. It's just the lower may be protruded more. A lot of times the maxilla in these cases is at least normally where it should be, or backwards. It's rarely, unless they have a lot of tooth tip, it's rarely that the maxilla is anterior where it should be. So usually it's the lower. So the idea of pushing things back in the airway, I don't like. I don't like that type treatment for those reasons. These kind of cases, I like to bring the mandible forward and get the airway more opened up. In these class 3s, where you've got you've got a retrognathic maxilla where the upper jaw is way behind the lower jaw, these are usually because again, there's lack of forward growth development of the maxilla, and you've got to treat these kids early. If you get them at about this stage, it's a surgery case, and you've got to do some things to advance the maxilla. This is kind of the way I look at my cases. I look at airway first. I look at airway first. I look at TMJ second. I look at the face third. I look at the skeletal parts fourth, and the last thing I look at is the teeth. Because in my mind, The teeth I can put anywhere I want to. The bones I can, with surgery and all sorts of growth modification and things, I can change the face. I can change the bones. I can, either help my TMJs or maybe aggravate them if I'm not careful. But the airway seems to be something that, we need to kind of be a little more aware of. The position of the jaw, the tongue position, and all that that is related can affect this, and it definitely can in one way or another. And then you've got your class one. A lot of these are maybe again retrognaathic, and things need to be brought forward instead of back. But that's still in a little bit of a controversy today in the world of orthodontics. But I don't see that it should be. I mean, it should make sense. It makes sense to me. You've got these long vertical facial patterns, which are related to mouth breathing. Of course, there's a huge genetic component to these, but a lot of these patients, they live in the same environment and they breathe the same air, and they breathe, they're in the same environment too. These narrow arches, it just makes sense to me when the arches are narrow. The tongue just doesn't have a place to go. It's going to adapt, but what is it going to adapt into? It's going to adapt into the airway. So you get cases like this that are in the mixed dentition, and a lot of times we might just watch these a little bit. Class 2, this patient's so class 2, we got real narrow arches. This is where I like to see them and get involved, maybe not necessarily with palatal expansion, but some called E-arches. I'll show you what those are like. But they're little arches that actually upright the dentoalveolar segments and try to get the teeth in a better, in a wider position, which makes more room for the tongue, which makes more sense to me that helps the airway. So you got these high arch palates, and you got intermolar widths that are less than 30 millimeters, which there's no way the normal tongue is going to fit in there. And this is where our myofunctional therapists and speech language pathologists can help us out. But a lot of times we have to get in there and reshape this. We have to reshape these palates. We have to get in there with our orthodontic therapy. And there are a lot of these expanders and things like this. Some of the expanders I like. Some of them take up tongue space, which is a problem. Sometimes you want to get in and out of some of these palatal expanders as quick as you can. And I'll show you why I use little E-arches. They're less restrictive on tongue space. You've got bilateral cross bites or unilateral bilateral cross bites, sometimes with mandibular shifts. Like this case, if you took their lower jaw and had them relaxed, their midlines would line up, but when they bite together, you can see that they actually deflect toward the side of the cross bite, which long term is that patient is their jaw, they're going to grow that way. And then all of a sudden you've got a whole different ball game to have to deal with. Now, I see this a lot. And some people say, well, why are you going to take Conebeam on some of these young children? Number one, we did a whole article about radiation dose, and the radiation dose of Conebeam now is low. The low dose Conebeams are actually less than a standard pan-ceph. People still are caught in the world that a Conebeam is very high radiation dose, but it's with some of the new lower dose protocols, I can do a 3D. I don't do a full field of view. I do a 1613 or 1610 field of view, which is just above the nose and the bottom of the chin, for about 15 to 20 microsieverts. A standard pan's about 24, and a standard ceph is about 6. So a standard pan ceph is about 24 to 30. And some of these low-dose Conebeams, you can get down to about 15 or 18 microsieverts of radiation dose. And you can see these kind of things where the lower 6-year molars are actually touching the lingual plate. And you say, well, you can't expand. Well, you can expand. You got bone out here to take these molars. This is where I use little Schwartz plates or or little E-arches I'll show you in just a second, where I can expand. Here, these are the 12-year-old molars in the middle of the socket. Here's actually a wisdom tooth, but look where the lingual where the constriction is. Constriction is from 6-year molar forward. You widen that out while they still have primary teeth, and you're going to make room. You're going to make room for a lot of these teeth. A lot of this is uprighting. It's not. You can't expand the lower arch like you can the upper, because the upper has a suture, but you can upright the teeth over basal bone in the lower. That's what you're doing, and you can't see this without Conebeam. We do not appreciate this type of a view, and we don't really appreciate the width of the even the upper molars. We can measure those clinically, but we get a better idea how that's related to the nasomaxillary area. Sorry about that. What about how early should we treat these kids? Now, that's a good question for us orthodontists. We say about 7, because that's the kind of a time we feel comfortable about doing that. But remember that about 50 to 65% of craniofacial growth is actually completed by 4 to 6 years of age. And by the quote normal orthodontic evaluation age, which a lot of times we may see them at 7 and just recall them, 60, 70, 80% of their facial growth is completed by that time. So by the time we normally start orthodontic treatment, 90-95% of facial growth is complete. And we don't have the capability. The problem is what's been happening with their airway and their development of growth during all this time. We've missed a lot of craniofacial potential growth and development if we wait. I like to see them now at about 4 to 6. If 4 is a little too soon, if I can't, if I just can't get the patient to cooperate, I'm gonna have to wait. But I'm not like a Kevin Boyd that can see them before they're born. But he can do it at 2 or 3 or 4 years of age. I'm not a pedodontist, so I can't handle them too much younger than about 4 or 5. But if I feel like I can get them in this stage when they're still in the primary dentition, you look at this little child right here, they're about 4 or 5 years of age, and everything looks, that's what we consider normal, but it's not normal. There's no spaces in here. They've got kind of a little deep bite. It doesn't look that bad. It looks pretty good. The parents will come in and say, oh, they had such pretty baby teeth. Well, they don't have space. They don't have room. They need to be expanded at this age. This is the time that you should do it. And you get in there with some little simple appliances and space that out, and you just be amazed at what kind of room you can make and how cooperative they are. You get these. This is kind of right up y'all's alley about lingual frenums and posterior and anterior tongue ties and those kind of things, and all the tethered oral tissues. And it's just obvious to me, if the tongue can't get in the roof of the mouth and be in the proper place, you need to do that as early as possible. I know there's still some controversy and all that, but it doesn't make sense to me to leave tissues that are not functioning properly in the tongue, especially because that's nature's expander of both arches, of the upper and lower, and the advancement. If the tongue can't get in the right place, then you're defeating your whole purpose. So you need proper tongue function. You need proper swallowing. These are just red flags for sure. No spaces. No spaces in the teeth. The teeth, you can see they're all kind of lingually inclined, and then the deep bite. Some things that we can look at intraorally, of course, is what's called this Tonsillar Classification. This was actually designed to help anesthesiologists figure out how easy it would be to intubate patients. So what they would have the patient do is open their mouth and stick their tongue out. Don't say ah, but just stick their tongue out and see if you could see the oropharynx or not. In other words, if they were class 1, stuck their tongue out, and you could see the oropharynx and the uvula, then that would be a pretty easy case to intubate. As you get up through the classification, you can see that patient would be harder to intubate. Well, sleep disordered breathing got involved in this and said, well, what about the tongue being in the way of the airway? So we use this classification too to classify tongue position, and this is a crowded tongue. 3 and 4, these are high risk for potential sleep apnea. It's not diagnostic for sleep apnea, but it's just a high risk factor because I haven't seen very many people that have big tongues. I've seen a lot of people that have narrow arches and the tongue just won't fit in there because the arches just aren't big enough. And you make the arches big enough and then the tongue doesn't look so big anymore. So that's but I have seen some that are definitely big tongues, but rarely do you ever see that. The tonsillar classification, you look in there, if the tonsils are gone, it's classified as 0, class 1, 2, 3, and 4. 3 and 4 is when they're actually kissing tonsils. So that's another thing we look at. That's another thing that I look at on the Conebeam when we look at it. Because some of this you can't see clinically. I've had a lot of this missed by even the pediatricians where they'll look in the mouth. They might see a little bit of looks to be obstruction up in the top part of the tonsils, but the obstruction is really down deep, and we'll find it on the Conebeam. The other is this scalloped tongue, which we see all the time, and to me this is just kind of screaming that, hey, I need more room. I need more space in here because I'm trying to stay out of the way of the airway. And this is what, speech language, this is what SLPs and oral myofunctional therapists and look at all the time is the tongue. Where should the tongue be when you swallow? The tip of the tongue should be right behind the front teeth, and the middle of the tongue when you swallow, should be in the top of the palate. And there should be a certain amount of room that the molars have got to be anywhere from about 36. This is 42, but I would say anywhere from 35 on. The average tongue needs a certain amount of room to be able to get up to the roof of the mouth. The tongue is the one thing that bodily moves the maxilla apart. The maxilla has a suture, and it normally widens when there's lateral movement of the tongue in the proper position. When the tongue, either for maybe nasal resistance breathing or whatever, and the tongue gets low, then all of a sudden you start, the maxilla starts to narrow up, the palate starts to arch, and the tongue doesn't have enough room to fit in the mouth. Then now all of a sudden the width of the molars start to decrease, and you can start seeing them as little as 28 millimeters, 30 millimeters. Even at 37, that could be considered by some to be kind of normal. It's maybe on the low normal side, but you get a lot of these different kinds of looks. Some of them are cross bites, some of them don't have cross bites. I see number 3 a lot, where the upper and lower teeth are leaning lingually, and these are the kind that where I get in there and I do some early expansion. It just makes sense to me. So these are things that I use a lot. We showed that again, that lower occlusal view, which I can only see with the Conebeam, of seeing. I haven't really measured. I don't know what this measurement should be, but I know the lower molar shouldn't be touching the lingual plate of the mandible. If you look at where the second molars are, to me they should be in the middle of that trough. But these are little E-arches that I use a lot. They're actually banded to the 6-year molars. They're soldered to these 6-year molars. There's actually, this is a wire that comes up that has a tube in it that's soldered to this wire part on this one side. There's a wire up under this spring. This is actually a spring that the wire actually goes all the way up to just about the other side. So I'm going to show you as it expands. So this spring is spring loaded, And so what this thing does over time is it just uprights the teeth. It's not bony. It's dentoalveolar expansion is what you're getting. Now, I use a lot of these even on the upper if they don't have cross bites. Now, if they have cross bites like number 5 over here, then that's when I've got to get into a rapid palatal expander with a screw and do some disjunction of the upper jaw. Sounds kind of crazy. It sounds, but you've got to get in there and get that upper. That's the most rapid way to do that. But most of the time, I'm doing these. If you look real carefully at these E arches, guess what? It doesn't interfere with tongue space. Both of these upper and lower, after they expand, let me see if I can get something. All right, hang on. Why is it not going? Wait a minute. There we go. You could see how that even in the upper one will come across where they won't bite into it, but basically what it does, it expands, and you can see it doesn't have a lot of stuff to it, so it doesn't interfere with tongue space. After this, after you get the teeth wider, if you'll just let it sit passively, what you will find is the tongue itself will actually start doing the expansion. And the little spring, you'll start seeing a gap here. The wire, it's not active, but you'll start seeing the expansion continue on its own because the tongue's doing the work. So that's an interesting finding that I look at. And what I like in this too, people say, well, why, how young should you treat them? Well, guess what? When they treat kids that have club feet or pigeon toed, how young do they treat them? Extremely early. They see them at 1 month or 3 months. And why do they do that? They take a child like this in figure 1, they put them in cast, and they overcorrect their feet, and then they put them in corrective shoes, and by the time they start walking, you hardly ever know they had a problem. This is the same child. All the way through figure 1 to figure 4 is the same child grown up as an adult. Now, it's not perfect. You can still use some corrective shoes here, but it's a lot better than doing this. What do you do at 5? Here is surgery. That child will never be the same. Now, it's a little extreme here, but the point is, you can take this is different bones in the maxilla and all that. And we'll take that argument. But the point is, it's the same principle. You're taking a child that's moldable, you're molding the growth and development and creating something that's more normal. And then when you actually get to a point where you might need, quote, braces on the teeth, then you have just a lot simpler situation that you have to deal with. So this is kind of how I liken it to, and this is kind of how I explain it to parents. They understand that. There was a study done, because I do use Conebeam. I do want to know kind of what the airway is. I don't use it as a definitive marker, but I'm looking for a lot of things in the Conebeam that to me make it worth the dose. When I do a young child, it's a very low dose and a low field of view. I don't take a full field of view. A lot of these studies that have been done on dosage for Conebeam have been done on the full head and the highest doses, and that's what they've been reporting on. Nowadays, those dosages are pretty significantly low, and at sometimes even less than a pan-ceph machine. But I do follow the ALARA principle. The low is reasonably achievable, and unless there's certain specific clinical things that I need to know, that's when I'm going to take a Conebeam. If I'm looking at certain signs on the face that relate to airway allergy things, I need to know about the sinuses. I find a lot of pathology in the sinuses. I would say well over 50% of these little patients that we see, I'm sending them to ENTs for tonsil and adenoid evaluation, a lot of sinus pathology, a lot of polyps in the nose, a lot of allergic rhinitis and things like that that make it, in my mind, worth the effort. And we go over that with the parents. I don't have anybody that's really had a problem with that. You get some parents ask questions about it, but most of them, once they see what we're looking at, they're glad we did it. This was a airway growth and development, a computerized three-dimensional analysis by Dr. Stephen Schindel, was a former chief of plastic surgery at Stanford, and Rick Jacobson is an orthodontist in California, and they took a number of patients, I think about over 1,000 patients, and they measured on Conebeam. They measured these were patients that had no sleep disorder breathing issues, and they had taken the Conebeams for other reasons, but they were considered normal airway measurements all the way from about I think it was about from 6 to 60, but 5 up to 60. But they measured these airways. Now what I did is I put it in a graph form to make it a little bit easier for me to understand. But they made them into age ranges from 6 to 8. The average male minimum cross-sectional area of the airway was about 85, 74. You can see that it tends to go up, hits maximum at about 21, 22 years of age. So it starts down here at about 6 or 8. It grows to about 10 a year till it gets not quite to 200. And then if you look at the difference between male and female, here's female, and their airways tend to drop off a lot shallower than us males. And maybe that's why females live longer, because your airways last longer. But anyway, it tends to go up. And so your airway at about 20, 21, 22 years of age is about as big as it's going to get. So my whole point is, here at 6 or 8 years of age, if we've got an airway that's way down here, I want to try to make that as large as I can, as quick as I can, so that when they get up to 21, maybe their airways are up here and they have a higher diving off point, so to speak. I've never heard of a negative of why you shouldn't have a bigger airway. That's probably not a bad thing to have. Here's some articles about pediatric sleep disorder breathing in orthodontic population, which I thought was really interesting. Let me go back here. Here are the results of this study. There was a 10.8 prevalence of positive wrist disordered breathing was found to be significantly higher in the general pediatric orthodontic population than in a healthy pediatric population. So 11% higher prevalence of positive risk of sleep disordered breathing in a pediatric orthodontic population. Presence of snoring was about 13.3%, sleepiness of 17.9%. Among the comorbidities of nocturnal enuresis, 13%, overweight, 18%, attention deficit disorder. Look at that number, 32% had a higher prevalence in the orthodontic population with higher sleep disordered breathing risk at a level of 0.05. So they had almost a third of those patients had some form of attention deficit hyperactivity disorder. I mean, that's unbelievable. The conclusions from that study: there's a higher pediatric sleep disorder breathing risk prevalence in the orthodontic population. It makes sense. That's the group that has malocclusion compared to healthy pediatric population. So we orthodontic practitioners should be screening for these sleep disordered breathing as part of our routine clinical exam. And that's kind of what the ADA, that CAST committee, is advocating. We're looking at doing a validation study That's where we are right now. We've presented this to the ADA, and we're looking to do about 300 or 400 children. We want to give them all the we want to validate the questionnaire. We want them to all go through polysonography. There's actually a little ring that we saw at the meeting in Atlanta this past weekend called Sleep Image. It's a little ring that measures pulse oximetry, among other things, heart rate variability, and some other things, which would be a very practical way to screen these kids. So what we want to do with this study, we got to get funding for it. That's kind of been the holdup. To actually do about 400 or 500 of these kids, have them go through the sleep questionnaire, have them all go through the polysonography, also do the ring, and maybe even do some 3D facial imaging, and then compile all that together and see how the screening form validates to the polysonography, how the screening form validates to the ring, and then how the ring and the polysonography apply to each other. So it's a pretty good, it's a pretty big study that we're in, a pretty big deal that we're trying to do. So it may be a few years before this is done, but just kind of be on the lookout for it. I think it'll answer, a lot of questions. Children with ADHD or sleep disordered breathing. There was a study. There was a large clinical study of more than 11,000 children, found that those with sleep disordered breathing were significantly more likely to show signs of hyperactivity, trouble interacting with peers, and conducting issues of aggressiveness and inability to follow rules. The study examined the effects of sleep disordered breathing in children as young as 6 months. Researchers found that very young children who experienced some of the sleep disordered breathing by age 7 had 40 to 100% more likely to have behavioral issues than those similar to those used to diagnose ADHD. Isn't that, that's a big study right there. The 3D imaging has also, as a side note, has been looked at early, looking at autism and the recognition of autism in young children. And autism seems to be related to early testosterone release. And what there is kind of a masculinization of facial morphology in girls and boys. And if we look at these two charts, I'm going to kind of just go over this a little bit, but this would be the normal growth of a girl here. I think that's right. Let me see. Hang on just a minute. Yep. This would be, yes. This is the normal. This line right here is kind of normally, well, let me see. Hang on just a minute. Let me look. No, I'm sorry. This would be the normal growth of a male child here. This would be the normal growth of a female control here. But when they start getting more masculinized, in other words, well, it actually shifts the other way. I'm sorry. This would be the normal female here. And when you get more autism, when the autism tends to show up, you tend to get a more shift toward the autistic child seems to have more masculine traits. So this would be the female with autism, male with autism. So they tend to get shifted toward this more masculinized face, which I thought was kind of interesting. This is the first study to examine facial masculinity in the prepubescent sample of children with autism spectrum disorder using 3D imaging measurements of objective indices. Boys and girls with autistic spectrum disorder were found to have more masculine facial features compared to age-matched typical developing controls. Increased facial masculinity was related to greater severity of social communication behaviors. While the current evidence for the association between ASD and prenatal testosterone exposure is mixed. The present study extends on a recent finding linked elevated prenatal testosterone, increased facial masculinity, further evidence for hypermasculinization of account of autism spectrum disorder. So there's a lot of things like that that are being studied in the world of 3D. I wanted to show you, this is a little, about a 3-minute tape on Airway and Tmj. And I think it brings to light a lot of things that we're talking about, how Tmj and Airway are kind of related.
Airway and Tmj. The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt. The result is a deformation of the lower arch known as the bicuspid drop-off. The result of this deformation of the upper and lower arches is the presence of premature contacts upon closing, which shift the lower jaw distally off of the physiologic trajectory. The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward. Upon opening, the disc can shift onto the condyle to restore the TMJ's correct position, reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headache. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backward. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain. Airway.
Wow.
So that kind of shows a little bit. I've got a lot more. I don't know how much longer do we want to go?
Do you want to do a part 2 and we'll finish?
We can. If y'all are I know an hour is about enough. I've still got some more stuff. I've got some cases and stuff we could show,
Yeah. Let's do a part 2 because this is fantastic. I told you, you were blowing my mind, Dr. Harrell.
Okay.
What a wonderful class. I am so excited that you guys are here and you're lucky enough to be able to hear this. People are voting over here for part 2.
All right.
So
sounds good to me.
Because I'm blown away. I don't even know what to say. There you go. More people saying part 2, part 2. All right. So if you guys have any questions, should we just answer everything on part 2? Should we answer a couple questions about what we've seen so far?
There's one up here says is SRBD preferred term in lieu of SDB. It's the same thing. Sleep-related breathing disorders, just probably a little more descriptive as sleep disordered breathing. It's kind of the same thing. Why stroke's most prevalent in consequence of OSA compared to other things? Well, the thing about it, when you have OSA, two things happen. You've got you're decreasing oxygen to the brain. I mean, that's like number one. But you're also the effort to breathe is there too, which actually, taxes your heart. So your heart and your brain is cardiovascular and neurological are the two main, big effects upon sleep, snoring and sleep disordered breathing. Snoring in and of itself, the noise from snoring, they think may even be aggravating the stroke somehow, and I don't understand all that, but you got a lot of things going on. But probably, I think you got that lack of oxygen that is directly affected in the brain for sure. It's treating earlier before age 6 your molars. I'm attaching the expander usually to the primary second molars. I'll use those E-arches a lot of times. Maybe even quad helix, but I like the E-arches because they're just automatic.
How long do you usually keep those?
Do what?
How long do you usually keep the E-arches?
I'll keep them in there about a year. I mean, I'll keep them in there. I'll have them kind of pre-programmed as how far as I want them to, because I don't just let them keep going and going and going. I kind of have them pre-programmed to stop. They'll kind of run out of gas. In other words, there's only so much you're going to get anyway, and then they're going to come apart.
Okay.
But what I do is I normally cut them so there's a couple of millimeters shy where the whole thing doesn't fall apart. And then I'll just let it sit. And then, like I said, a lot of times what happens, the tongue will just keep expanding itself. Yeah. And then when that starts to happen, I'll just take them out and let them sit without anything in there, and then just let the tongue do its work naturally. Because now I've gotten the teeth out of the way.
Exactly.
Yeah.
What is the whole process? So if I bring Zoe to Alabama, personal question, how often would I usually have to see you within the year?
Probably, normally what I do is I put those in, I'll see them in a few weeks, 4 to 6 weeks, and then, but you could do kind of photographic, you could do photographs and stuff and kind of look, but just as long as the bands are cemented and they're still on, and you just, a lot of times I'm looking at them and going, yeah, everything looks good. You could even do it through photographs.
Okay.
And do it through a telemedicine kind of thing where you can just look and say, yeah, everything's looking good, nothing's loose, everything's expanding, and then you probably every 2 or 3 or 4 months or something like that would be, so you're actually looking at them.
Perfect. Guys, my gosh, I don't even know what to say. I don't think I've ever been speechless here before. So this is what we're going to do. We are going to schedule a different day for Dr. Bill Harrell to come back and finish his presentation. I do want to thank David Jacobson. Is it Dr. David? I don't know. You just became a member. Thank you. You're our number 62 member. We're super excited. And I was just thinking over here to myself, this is so valuable. These classes are so valuable. And we have 4 of them. So 4 Zooms a month, about 4 Zooms a month. And we charge $25 a month for you guys to be members. That's about $6 a class. And then you add Clubhouse, you add the product discounts and the research folder. It is really a no-brainer. So if you guys are not members yet, please join us. I see a lot of names over here, familiar, that are already Airway Circle members. So first of all, I thank you. And then second, the ones that are not, come on guys, join us. We are a cool group. And we're going to get to rewatch these. We're going to, there's a lot of Zoom calls that we already have out on YouTube, but started September 1st when we started our membership. I'm going to be taking them off the air, so you will not have this lecture available anymore. only if you're a member, you can rewatch it. So thank you, Dr. Bill Harrell. You're always wonderful.
Thank you.
I'll get with you and we'll schedule a different day then to come back.
Okay. Sounds like a winner. Thank you very much.
Thank you guys. Have a wonderful night. We'll see y'all later. Bye-bye.
Bye-bye. Thank you.